Good morning. I just want to warn you that there are no microphone or video capabilities needed to participate, that you can ask questions at any time. They will be anonymous. Please use the Q&A feature. And if you could keep the questions as brief as possible. This webinar will be recorded and it will be available to all of you. I'm thrilled to introduce the participants in this webinar. Given the last 2 years dealing with COVID, the need for teaching and developing novel and important skills in respiratory and critical care is absolutely clear. COVID will not be our last virus to plague us. Refining mechanical ventilation so that patient outcomes are even better than what we experience today is why we are presenting today. I am Jeanine Wiener-Kronish, and I became an intensivist well over 40 years ago, and caring for patients with respiratory failure is one of the reasons I became a doctor. I am so excited to tell you about the improvements that have occurred because of the team that you're going to hear from today. I will first introduce Lorenzo Berra, who is our Medical Director of Respiratory Care at Massachusetts General Hospital. He, along with our beloved late Robert Kaczmarek, created the Lung Rescue Team, which we are going to talk about today. Dr. Berra was recruited to MGH by the late Warren Zapol, the physician scientist who helped bring nitric oxide into medical practice. And by doing that, there were thousands of premature infants who had their lives prolonged. Dr. Berra has created a unique team that now helps all clinicians treat severe respiratory failure in morbidly obese patients, in very elderly patients, and in premature infants. His treatments are also used in the operating rooms and in the recovery room. Our second speaker is Dr. Ryan Carroll, who is a pediatric intensivist and the director of Global Pediatric Critical Care Medicine. He was instrumental in the creation of protocols and grants for the delivery of nitric oxide to infants, children, and pregnant women during the COVID pandemic. And he will be able to show that he improved the outcomes in these COVID victims. Our third speaker is Carolyn LaVita, who's the Director of Respiratory Care at MGH, and she has a BS in Cardiopulmonary Care Services, and then became the respiratory therapist at MGH. She is the clinical specialist for respiratory care, and she has been since 2014. She works to ensure that our therapists are continually learning and improving, and she has been involved in teaching our respiratory therapists the use of electrical impedance tomography, a skill set that we are going to speak about today. It allows individualization of mechanical ventilation treatments for all patients, including victims of COVID. Our fourth speaker is Kenneth Shelton, a specialist in cardiac and intensive care anesthesiology, and now he's our chief of critical care at MGH. He is also the medical co-director of a 34-bed unit that is led by a combined program of general cardiology, cardiac surgery, surgeons, anesthesiologists, and cardiologists, and emergency medicine physicians. Dr. Shelton is involved with the MGH ECMO program, which was very busy during the COVID pandemic, and which has greatly benefited from the lung rescue patient service and education. I would say the future holds much promise. The devices, treatments, and experience we are going to discuss today will help you understand that we can offer better outcomes for our future patients. And it won't matter what the age of the patient is, what the size of the patient is. This is treatment for everyone that individualizes treatment. The goal of academic medicine and respiratory therapy is to continually improve, and we're going to provide you the data that shows we are. Dr. Berra.
Thank you, Jeanine, and I want to thank everyone for connecting with us and for participating today to this webinar, and for the people that will listen to this recorded session. I will provide a brief introduction of the lung rescue team, a service that we created at Mass General to treat patients with respiratory failure. Before doing that, I wanted to acknowledge that many of you that are now listening were our patients in the intensive care unit, in the operating room, on the maternal fetal medicine floor, and in the pediatric and adult surgical and medical department. It was an honor to care for you in such difficult times. We all learned a lot in the interaction with so many of you and with your families. And we hope that you are fully recovered and you are on your way for recovery. In my talk, I want to give you a glimpse of what the lung rescue team is. And I will do that by providing three main features of the lung rescue team. The first feature is that the respiratory care and the care of the lungs is a very peculiar discipline. And let me explain why. If one has a neurological problem, the patient will be directed to the neurology department. For example, if a patient has a stroke, the patient will go to the stroke unit. If one has a cardiac issue, then will end up to the cardiac floor. If a patient is pregnant, then the patient will go to the maternal fetal medicine department, and so forth. Lung failure and eventually acute cardiac failure secondary to lung failure is slightly different. Respiratory failure can occur in any medical condition, during pregnancy, after a trauma, after a cardiac event, and of course, more recently in patients with COVID-19 pneumonia. We understood that we had to move towards the patient rather than the patient going to a specific location of the hospital. So we created a lung rescue team. This is a new concept that no other hospital in the country has. This team travels where a ventilator is, where a respiratory support is needed, where a new respiratory therapy needs to be developed or built for a specific patient with a specific condition. And we work with the team on the floor to reverse the cause of respiratory failure. That is the reason why our team is a multidisciplinary team. As you heard before, we have a critical care physicians, respiratory therapists, pediatric physicians, cardiac anesthesiologists, and more. The second feature, by 2012, about 10 years ago now, together with the late and beloved director of respiratory care, Dr. Robert Kaczmarek, we created the first structure of what became the lung rescue team. We quickly learned that differently from other disciplines, where universal protocols or therapy are used, respiratory support had to be titrated to the single individual conditions. I'll give you an example. If I need to provide you with a respiratory treatment, for example, oxygen, not everyone will tolerate the same mask. If one has a mustaches and beard, then this patient needs a different interface. So what works for one might not work for another person. Similarly, it is used the artificial breathing machine. So we call it mechanical ventilators. I'm sure you heard a lot about the use of breathing machine during COVID-19. It is obvious to everyone that I cannot use an artificial breathing machine in a 5 feet petite woman as I would for a 6 feet, 400 pounds man. However, at present, ventilation protocols are the same, no matter what condition the patient has. So we had to study and develop novel methods to adapt therapies to individuals. We developed multimodal respiratory monitoring, we created novel delivery systems, and we found new therapies. We learned that if we wanted to meet the needs of a patient and efficiently reverse the underlying cause of the disease, we had to be flexible and adapted to the patient's conditions. That is the reason why We have also biomedical engineers with us that build novel devices. We have scientists that understand mechanics of the lungs and innovators to deliver new treatments for different lung conditions. The third feature, which will be discussed later in more detail by Dr. Ryan Carroll and the Director of Respiratory Care, Carolyn LaVita, is training and innovation. I only emphasize here that we learned that in order to be successful in our mission, we had to build an education curriculum for novel generations of physicians and respiratory therapists, expanding on research in respiratory care and novel technologies. Both training and innovation will help to provide better respiratory care to all our patients like you received. And I assure you that you would not have received it if you were in a different hospital. In summary, at Mass General, we create a new paradigm of medicine for the treatment of lung failure with the creation of a lung rescue team. This team needs to travel to where the patient is and to personalize care to the specificity of the patient conditions. To make this paradigm of medicine stable, we need to invest in education and continue innovation. Thank you, and I'm available for any question today, or you can reach me by phone or email at later time. You will find my contact on the Mass General Hospital website. Thank you again.
Good morning, everybody. My name is Dr. Ryan Carroll. I just have some slides to share. Great. It's an absolute privilege and an honor to speak with all of you today. Working with this team has been a pivotal interlude in my life. And so it's just wonderful to be able to speak about what Professor Berra and his team and Carolyn have done with the respiratory therapy and intensivists here. The overall theme to me of the lung rescue team is really expanding on a legacy of discovery and exploration and invention and care delivery. You know, really sustaining visions of our brave and beloved mentors, both the late doctors and Professor Bob Kaczmarek and Professor Warren Zapel, really two pillars of MGH respiratory anesthesiology and critical care. And you've heard their names mentioned, and we probably will hear them mentioned a few more times. And really, they brought us up in this beautiful ecosystem of the MGB, the Mass General Brigham, and with all of our partners across town, et cetera. And to me, the lung rescue team is a culmination of our efforts in research and care delivery. You know, at the focus of this is really patient care. It's a vehicle, really, a multifaceted approach to enhancing survival from respiratory failure by expanding our understanding of pulmonary mechanics, for example, or cellular and molecular interactions and pathophysiology, while assessing novel technologies and therapies that were born out of our various labs, thereby really crafting ways to individualize care. Individualized care, as Dr. Berra was talking about, is definitely a new theme in medicine. We can individualize chemotherapy, et cetera. But not all lungs are created equal. And when they're infected, they're really different from each other. And just treating one patient to the next in a similar fashion has been the way that we've been relegated over the last several decades. And with Dr. Berra's team and our respiratory therapists, we've really been able to hone in on ways to establish, detect ways that patients' lungs are different, and therefore individualize their therapies, whatever they may be. So really harnessing the strength of MGB research, clinical and innovations ecosystems, and we're expanding programs into new spaces. We're investigating new diseases, developing and assessing cutting edge technologies, and branching out to my favorite space, which is pediatrics. One of the beautiful things about Mass General itself is that we're a mixed pediatric and adult hospital, and there's a bilateral exchange which was brought really to the forefront during Surge 1 and 2, as we took care of 49 critically ill adults with ARDS and COVID-19 in our pediatric ICU, and required a constant conversation. And I also come from the Berra lab, where we work predominantly with adults. And so we have this ongoing conversation really around a drug that we've used for years for children, nitric oxide. And that'll be a theme we'll be talking about. Now, a Mass General, MGB, but really Mass General here, where I'm sitting, and I'm actually looking at the ether dome here. We strive to be first, not in a silo or standing alone, but as a collaborative team, gleaning from the ecosystem afforded by the Mass General Brigham, Harvard, MIT, and nearby industry. That said, we really recognize the power of collaboration with institutions across the country and the globe. And we have grown through our relationships with colleagues and institutions on every continent, including Antarctica, which we won't get into today. But to me, if I wanted to define the lung rescue team, and Dr. Berra covered this, and Carolyn LaVita will also talk about this, but to me, there are four main pillars of lung rescue team: intervention, investigation, and innovation, and training. Or I maybe call it investment, investing in our colleagues and investing in the next generation. I wanted to kind of have the four I's, but wasn't so sure if I could stick with the theme. Anyway, let me just break these down a little bit. With intervention, let's just give you some numbers with regards to what the lung rescue team has been able to do over the last, now it's about 10 years. Really, and we should emphasize that the lung rescue team was up and running from its inception pre-COVID, and it was brought to the forefront, and I would say matured and catalyzed into maturity rapidly during COVID. As you can see these numbers, for pre-COVID, the team was working with about 238 different patients, most of whom were mechanically ventilated. And a major focus of Dr. Berra's research at that time was trying to describe how we treat patients who are morbidly obese. We didn't take care of any pregnant patients at the time. Pediatrics, there's one case that we worked on together. And then with INO means inhaled nitric oxide, which is something that we, a gas, a therapeutic gas that we hold dear to our hearts. We worked with quite a bit on several patients. There were several ECMO consults, and ECMO is extracorporeal membranous oxygenation, when the lungs really are totally in failure or the heart is in failure. We take all the blood and we oxygenate it and clean it of its carbon dioxide and return it to the body using a series of special pumps. And then COVID-19, of course, pre-19 wasn't an issue. But during the pandemic, as you can see, the team doubled their number of assessments of patients, most of whom were mechanically ventilated, some of whom were obese. And we were brought specifically to intervene for young females who were pregnant and who had COVID-19 and who were in trouble. And we also have collaborated on at least 5 pediatric COVID patients. By pediatric, I mean mostly young teenagers. But we've also collaborated on patients who don't have COVID. We've also continued our nitric oxide efforts and ECMO efforts. As you can see, the predominant patients, but not all, during the 2020-2022 epoch of time were COVID-19 positive. Let's see if this switches. From an innovation standpoint, our lab and our collaborative efforts continue to investigate new ways to deliver either nitric oxide or to better understand lung mechanics. This is from a Science journal article years ago of a sparking device that creates nitric oxide at the bedside, something that's since been licensed. And I have no conflicts of interest with regards to that particular company, but this is a technology that we continue to investigate in the lab to provide nitric oxide at the bedside, either at the doses we use typically in the ICU setting, and now we're actually starting to investigate high dose nitric oxide as a antimicrobial. And here's Dr. Berra. During the COVID-19 pandemic, we were asked to try to deliver nitric oxide at a high dose to try to rescue patients who had COVID-19 who had not yet been intubated. And we had to build new technology, but we also wanted to make these technologies available to our colleagues across the globe. So we've published on this technology basically as an open source product. Investigation is the currency of academic medicine. So meaning, do we publish so that we can further disseminate our ideas and what we've done in our lab and what we've done in our respective ICU environments. So right away, people were asking us, what are you going to do about COVID-19? Not only to ventilate the hundreds of patients pouring into the MGB system, but also, do you have any novel therapies or devices? And so we were investigating, we embarked upon that journey very, very early on. You can see this articles from April 2020. I would say during the pre-COVID era, we had multiple publications focused mostly on obesity, as I mentioned, ECMO, lung rescue team overview, nitric oxide and cardiopulmonary bypass is a novel therapy, and high flow nasal cannula and outcomes. During the COVID-19 era, we have multiple publications, up to 43 coming out of this effort, 8 for COVID, 17 for lung mechanics, 13 for high dose nitric oxide investigations, and 5 for operational approaches to the pandemic within the MGB universe. And just some screenshots of those various publications. To us, as a training institution, investing in the next generation and in our colleagues and being lifelong learners is absolute paramount. So we've trained 27 fellows, some from the United States, but a lot of them from Italy, Brazil, China, Japan, Germany, and Thailand. Anesthesiology residents and interns have been integrated into the lung rescue team and trained to enhance their training is up to 15. And the respiratory therapists, which is a massive team, several of them have been specially trained in the lung rescue team concepts. And little by little becoming more and more adept at these other technologies. And so I think investing in the future, investing in our team is a major theme. And this is just a screenshot from our lab at some point during the pandemic. So I thank you. I'm also available at any time. You can always contact us and post your questions in the Q&A, and I'll be running Q&A at the end of this. So thank you for your time. Again, it's been a wonderful, absolute wonderful journey to work with this team.
Good morning, everyone. My name is Carolyn LaVita, and as been mentioned, I'm the Director of Respiratory Care Services at the MGH. About 20 years ago, I came to MGH as a student, and what attracted me here was the volume of opportunity. My boss at that time was the late Dr. Bob Kazmarek, and his visionary thinking created an environment where respiratory therapists learned to work at the top of their professional allowances. Bob was intimately involved in research worldwide and brought the latest treatments and technologies back to our department, but most importantly, back to our patients. Developing the Lung Rescue Team initiative supports the MGH as being a leader in the respiratory care profession. At current, there are only a handful of hospitals in the United States who use Lung Rescue Team type therapies. And as Dr. Berra mentioned, none have a comprehensive team as we do. And generally speaking, these advanced skills are discussed only briefly in most respiratory therapy educational curricula. This means that MGH needs to be, and really should be, the leader in education around lung rescue team therapies. Although we have developed some instructional lectures, both theory and technically based, there's still more work to be done. Physicians and respiratory therapists also need time to learn and practice and refine these new skills. When others discovered that we had an interest in further developing our team, they began reaching out. A respiratory therapy colleague of mine at the University of Virginia contacted Dr. Berra and I to discuss this, and they're so interested in sending their RTs and physicians to train with ours. It's so important for us to continue Bob's passion for education of current and future respiratory therapists and to invest in them and their growth. Every economic business model talks about supply and demand. The demand for respiratory therapists after this COVID-19 pandemic far exceeds the supply. To this end, I do a significant amount of recruitment lectures, and what most students are looking for is exactly what I looked for: opportunity for growth. The best and the brightest respiratory therapists want the challenge of developing new skills and doing so often. Having the ability to offer skill development in the area of lung rescue team will attract strong and brilliant respiratory therapists, which just strengthens the overall critical care delivered here at the MGH. I'm currently taking a leadership development course with the Mass General Physicians Organization. One of our guest speakers used the analogy of storytelling to help shape our strategic plans. The speaker showed a slide that had a picture on it. In the foreground was a tortoise with a real determined look on his face. In the background was a rabbit or a hare with this look of surprise and beads of sweat forming on his brow. At the bottom left-hand corner, there was a picture of the finish line. The speaker asked the class what we thought of when we saw this picture, and nearly everyone agreed: slow and steady wins the race. Pictures lead to commonalities and can cross all languages and all cultures. They say a picture is worth 1,000 words. And what the lung rescue team brings to the bedside is a literal picture of the respiratory physiology along with precise data that allows us to better define the clinical status of the patient. Much like oncologists use CAT scans to monitor cancer growth and obstetricians use ultrasounds to monitor a developing fetus, physicians and respiratory therapists can use these actual pictures developed at the bedside to guide interventions and treatment. I'd like to offer you 2 patient cases. The first is really a group of patients, all with COVID-19 pneumonia. The Massachusetts General Hospital cared for more patients receiving mechanical ventilation than any other hospital in New England. The sickest patients were transferred to us for advanced treatment and therapies, and one therapy being ECMO. Dr. Shelton will expand upon this, but ECMO stands for extracorporeal membrane oxygenation, something you may have heard of in the news. It is the highest form of life support offered at the bedside in the ICU, and it can support the oxygenation levels in the lungs while the lungs rest and heal. It is a highly intense and resource-consuming therapy, but it's not a benign therapy for the patient. Therefore, there's always hesitation to offer ECMO, and the patient selection must be done so carefully. These patients with COVID-19 that came to MGH for ECMO were patients who had been treated at outlying hospitals, yet their pneumonia was not responding. The lung rescue team was called for many of these patients. The pictures and data collected demonstrated severe lung injury. For some patients, it showed us that the only hope for lung recovery was rest and ECMO. In others, the data helped us change the ventilator settings to actually avoid ECMO. With the invaluable information gleaned from the lung rescue team, the bedside clinicians were more confident in their decisions regarding ECMO. Secondly, I'd like to tell you about a case of a young patient. And before I begin, I'd appreciate if you could entertain my medical jargon for just a moment. PEEP is the pressure that's applied to keep the lungs inflated. If there's collapse of the lungs, the oxygen levels can drop and carbon dioxide levels can rise. If this is too severe or persists for a long period, death can result. One trigger for lung collapse is obesity. The pressure of the weight of the chest wall, as well as the weight of the large abdomen, exert compressive forces on the lungs. This is greatly magnified if a person is lying flat on their back. Typical PEEP level is somewhere between 5 to 15. However, an obese person may require higher, maybe up to 20. But too high of a PEEP level can also be dangerous. And so clinicians at the bedside are shy about arbitrarily just increasing this setting. Now back to our patient. She was referred to MGH for delivery of her newborn, as well as a medically required hysterectomy. This patient had significant obesity and was at severe risk for lung collapse during this operation. Dr. Berra and the rescue team were called to help. During the operation, it was determined through all of the advanced technologies that we employ that she required 28 of PEEP to maintain her lungs open. We were able to get continuous data, continuous pictures, and to change these settings as things change physiologically. I can assure you, no anesthesiologist or respiratory therapist would set the PEEP at 20 without this data confirmation. We individualized the settings and we're confident in doing so because of the lung rescue team. I'm happy to say this patient walked out of the front doors of the MGH to continue her life with her newborn baby. If the lung rescue team was not involved in her care, or her care was done at another institution, the outcome would have been vastly different. I thank you for dedicating your time to the MGH lung rescue team. We are forever grateful.
Welcome and thank you. My name is Ken Shelton. I'm the Chief of Critical Care Medicine in the Department of Anesthesiology, and today I'll talk about how the lung rescue service has helped us in the cardiac ICU of all places. So this is cardiac critical care in 2022, and it's about as complex as it gets. If you look around the room, you'll notice there's a device for just about every organ system. We have renal replacement therapy here on the left. We have our ECMO machine, our heart-lung machine, as Caroline mentioned, here on the bottom. We have our Impella device, which is another LV support device. We have an echo machine. We don't have a brain machine, but we do have EEG, and we're monitoring the brain. But this is cardiac critical care in 2022. And you may ask, well, where's the patient in this? Well, the patient is right there at the center of care. It's a little hard to see. But this is that patient 8 months later, after spending 8 months, believe it or not, in the intensive care unit. And it's a little hard to see on the screen, but I have another video that I'll show you. He's actually in ventricular fibrillation, so a lethal arrhythmia during this entire time. He's on biventricular support. If you look very closely, depending on your screen, you'll see that he has a right ventricle here, close to his right knee. The blood there is blue. If you look closer to the right, you'll see the blood exiting. This pump is red, and that's the left ventricle. But one thing you won't see is a mechanical ventilator. And this is a patient that's preconditioning for an upcoming heart and kidney transplantation and really reanimating after a massive heart attack in our cardiac ICU. And we called the lung rescue team to help us get this patient off of the ventilator so that we could convince the heart failure team to transplant this patient and to show everyone in the ICU and to show all of the other services that this patient was ready for a transplantation. This is that same patient playing the Wii video game with the nurse. It's a little, again, hard to see the screen behind him, but he's in a lethal arrhythmia. And he's up, he's walking, he's participating in physical therapy, and we were able to separate him from the ventilator with the help of Lorenzo Berra's team. A lot of fun. This is that patient, a video that his wife sent us after a successful heart and kidney transplantation in his backyard. And this is a typical report that we will get from Dr. Berra's team. And I think what it goes to show you is the amount of pulmonary edema that you will see after one of these massive heart attacks. And understanding the ventilator settings that we need for these patients is incredibly important to be able to separate these patients from the ventilator. What's changed since 2014 in our unit, as Dr. Berra mentioned, is that we are no longer siloed into single specialty units of care. It's really not the character of care that I think we provide in 2022, especially at an institution like Massachusetts General Hospital. We currently now have a patient-centered care model where we ask the consult services to come see the patient rather than sending that patient out to these different services. And the lung rescue team has become an incredible consult service, much like calling for a cardiac surgeon, asking for a nephrology team, asking for a structural cardiology consult. And the way that we like to set the patient is right there at the center of care and to bring in these various services. And the lung rescue team has become an incredible service throughout the entire hospital. And cardiac critical care has become very complex. In this scientific statement by David Morrow, you'll see we've gone past the days of an MI and rapid defibrillation. We've transitioned now to high forms of mechanical circulatory support, as the example mentioned of ECMO. We're discussing now therapeutic hypothermia and advanced modes of mechanical ventilation. Individualized care, an example I think that you can see with the lung rescue service. And this is fascinating data if you look at national trends of Medicare data over a 10-year period from 2003 to 2013. This is across 16 different institutions and over 3,000 admissions. And you might think that the most common reason for an admission to the cardiac ICU is perhaps coronary disease, but in fact it's respiratory insufficiency. So the actual reason these patients need the ICU is for respiratory failure. And almost all of these patients are on the ventilator. And the question becomes, how do you get these patients off of the ventilator so that you can take that patient and then transplant that patient or put them on a ventricular assist device and move their care along in the hospital? And that's another great example of why we call the lung rescue team, to expedite their care, to get them to the service that they actually need in the hospital. And this is what I think the future of ICU care will look like. Again, there's a device just about for every organ system that you'll see. But the lung rescue team is a key part of this. And just like we have renal replacement therapy and we have an ECMO machine, we will be using the mechanics that Lorenzo Berra's team is actually providing for us in the cardiac ICU to optimize the ventilator. There's obviously a lot of opportunity for data science and clinical analytics. The question then becomes, how do we use this data to provide risk predictions? How do we know which patients will benefit the most from a form of advanced therapy like ECMO? And how do we use this data to admit and monitor patients? How do we decide what patients to bring in from outside hospitals? And the goal obviously is to improve outcomes and provide efficient care, which we believe is better care in the hospital. As was mentioned, MGH has a long history of ECMO in our institution. With Warren Zapel, this is an illustration of ECMO in 1975 here at our institution. This, believe it or not, is the blueprint that we used for ECMO device manufacturing, I guess you would say, during the COVID pandemic, where with the help of the respiratory therapists and many of the other services in the hospital, we were able to create just 17 circuits. We had over 200 patients that needed ICU level care. And how do you decide which patients will actually need ECMO level care? And again, we relied heavily on the lung rescue team and Lorenzo Berra's team to be able to come and tell us what patients we can actually help with ECMO and what patients we cannot help. If you look at ECMO in our institution from 2009, when we think about H1N1 up through 2018, and then looking into 2022, you'll see we have over 100 patients that have been on ECMO in our institution. The question then becomes, how do you get these patients off of ECMO, and how do you decide which patients actually need ECMO? During the first COVID surge, we had over 500 consultations. These phone calls and text messages were taken from other outside hospitals, many in the New England area, and we have absolute contraindications and relative contraindications for ECMO. And how do you decide for the patients that are not going to qualify for ECMO, those that have bleeding complications on ECMO, which patients actually will benefit from a lung rescue consult, which patients may not need ECMO, and how quickly for those patients that are on ECMO can you get them off of ECMO so that you can free up a circuit for another patient coming in from another outside hospital. And I think the goal really for us is to be the hub of cardiac critical care in New England. There's an opportunity for remote monitoring and collaboration. There's an opportunity to develop relationships with other providers. And as was mentioned, we want to be the center that actually accepts patients that have been treated outside hospitals. And we want to be able to provide the care that we can at the type of quaternary center that we have at MGH. And this is a nice illustration of Dr. Berra and his lung rescue team in our cardiac ICU with patients on ECMO in an attempt to get them off of ECMO, again, to free up a circuit for another desperate patient. Thank you all for your time.
So I just want to summarize these exciting talks we just heard. Dr. Berra explained that the lung rescue team is unique in that it travels all over the hospital. It goes to any ICU and also goes to the pregnancy ward and to the operating rooms and the recovery rooms. And it personalizes treatment. And I will say that's so important in this day and age where our patient population has changed. We now have survivors of cancer. We have survivors of congenital heart disease. They present unique problems that need to be individualized. And Dr. Carroll presented the 4 I's that this team represents: intervention, investigation, innovation, and investment. And he did a spectacular job explaining how this team meets all of those. And Carolyn told us some very poignant stories that we help patients get the ECMO that they need or stay on mechanical ventilation that's titrated to their needs. And we also saved mothers who can be morbidly obese or just because they're pregnant have trouble with their lungs. And finally, Dr. Shelton presented the state of the art of we can help people transition to transplant after they have massive problems with their heart. And the ECMO team benefits from having the lung rescue team come and help them determine, do you need ECMO? How do we get off the ventilator to get off ECMO ultimately and move along? And we can collect data and use that data in the future for machine learning and AI. And with that, I'll turn it over to Dr. Carroll for questions.
Thank you, everybody, for your patience and for your time, and give us this opportunity to speak about this very truly unique and innovative force within MGH, MGB, and medicine at large. It's my opportunity to field some of the questions, and maybe I'll start with some that came up already through the Q&A. Feel free, there's a button, depending on which interface you're using or which computer operating software you use, your Q&A button might be in a different part of the window. Feel free to type in your questions. So maybe, Dr. Berra, I would ask, one of the first questions is, what are projects or areas the lung rescue team is working on that would greatly benefit from incoming funds? I'll start with that one.
Thank you for this question. I think we will so any support and donation that we would receive will be used for training of future generation of respiratory therapists and physicians into the lung rescue team. And specifically now we have a team that is formed by really 4 people: 1 biomedical engineer, 2 fellows that are a physician in training, and 1 respiratory therapist. So this is really what we would use the funds for. And specifically, I mean, I'm sure that if anybody is interested, we can discuss with our development office, Mass General, to create a possible also scholarship, endowment scholarship.
Great, thanks.
Can I
Yes.
just add? Sorry. I've been trying to get the lung rescue team into the operating room more frequently, but we're desperate for more personnel. We would need more people able to do the lung rescue. I would say at least 20% of the patients who come to the operating room are morbidly obese or have severe lung disease, and they would greatly benefit from having the lung rescue team there with them to help optimize mechanical ventilation during the operation.
Great. There's another question that I can help answer, as well as maybe Carolyn LaVita and Lorenzo. There's a question about, in your research and in our work as lung rescue team, we found there to be a vast difference in the ages between our patients. But I will say, as we mentioned sort of in the overview, I think that we've treated patients all well into their 90s or so, I believe, right, Dr. Berra? And then with regards to COVID-19, we've collaborated on unfortunate teenagers who've had COVID, ARDS, and heart, actually more lung failure, if you will, respiratory failure. This conversation has continued both with regards to some of the tools that Lorenzo's team has developed and is integrating into their practice, as well as some therapeutics. So we're using high dose nitric oxide as an antimicrobial, and we're embedding that in the lab. We're also utilizing it on younger patients. And then we're on the brink of moving some of the technologies that have been commonly used for adults into smaller and smaller children, because there are a couple companies that are willing to diversify their manufacturing portfolio and make their technologies smaller. This, of course, requires a relationship between the industry as well as some agreements. And some of these companies have allowed us to borrow or utilize the technologies to try and determine if children, pediatric patients in my pediatric ICU here, also have a heterogeneous or varied lung mechanics as we see in the adult population. Obesity is also a growing epidemic among young children as well. And so getting used to the kind of pressures needed in those young, delicate lungs will require more and more data so that we have a better understanding of how best to approach those patients. And Dr. Wiener-Kronish mentioned that we're probably not going to see the last of COVID for some time, if not even, unfortunately, maybe some other variants of other respiratory viruses. And getting to know how best to approach the patients who are infected with those viruses will be critical. And gaining, as Carolyn mentioned, gaining a more higher resolution picture of what those lungs act like will be critical to addressing those patients specifically. Feel free, anyone else on the panel who might be able to answer some of those questions. Maybe I'll throw out in the meantime, there's another question. Can you please speak more about the challenges that the lung rescue team faces and how we might be able to address them? And maybe Dr. Berra and then and Carolyn can answer that for right now.
So I think the challenges. I think the challenges that we need to face, certainly one of the great challenges that we had to face was COVID, as everybody understands. And we were lucky, really, that we had this team already built when COVID hit. And so my sense is that the most important part is to create expertise. And so that's why I think that we have been really focused on education and building a multidisciplinary team that is flexible and understands at the bedside patients' conditions. So I think that it's harder to have a recipe, but I think that certainly having and select good people that really is dedicated at the bedside is key. So for me, that is really in simple words trying to answer to this question. Certainly, like Carolyn said, these methods that we are adopting, the use of electric impedance tomography, the use of transpulmonary pressure, other devices and therapies, nitric oxide, ECMO, as we discussed until now. It's not as simple as it sounds. So it requires really training. So it requires time. So for people that enters in the lung rescue team, it requires time for learning. And so that's why I think our educational and the commitment is the commitment to working on this team is high.
I would just like to echo those comments from Dr. Berra that the technology and the therapies used with the lung rescue team are really novel technologies. They're not done, really throughout the nation or worldwide. They're upcoming and new innovative ways to look at patients and to understand their clinical picture. So in order for us to advance those, we have to spend time and we have to allow people educational time to get comfortable with those and to really refine their skills and to become the experts in delivering those therapies and understanding the data that we're collecting and interpret it correctly. So there's not much training, if any training, for respiratory therapists or physicians that currently exist that we can say, take this course. We need to make the course. We need to be the leaders, to be the educators. And so I think that's one of the largest barriers and challenges that we face, is that as we have many more patients than we used to have in the hospital, we have to find the time as a group to create the educational series and then to be able to employ our employees to become a participant and a part of those so they get good at all of these technologies.
I was just going to add, just as Carolyn mentioned, and I think this is not just a challenge for the lung rescue team, but for hospitals throughout. It's a challenge of capacity. And I think where we struggle as clinicians and bedside providers is we want to provide that same level of care for all of our patients. And so having the bandwidth to be able to provide this sort of lung rescue care for all the patients is key. Now, using a service like this to then say, this is the exact patient that we need to focus on, this is the patient that we can help, I think that would make all of the clinicians feel much better. And that's something that the lung rescue team can provide with the appropriate bandwidth.
I don't see any further questions at this time. I am happy to hand it over to our moderator. And so thank you very much for your questions.
So I'm very loyal to MGH, but what I would say, particularly to our industry colleagues, the optimal outcome would be that this skill spreads across the country, across the world. I would say Europe has already started their skill set in this area. I would like to think that we would not only provide this service at MGH, but help train people across the country. And that's good for you guys because they'll need equipment, they'll need skilled people to teach them as well. Our goal is to continually, just as you've heard, provide better and better care, and COVID has shown we need it. So I'm really grateful to my colleagues and to all of you who participated today. I think any of us are very welcome. And there is a question in the chat that says, can telemedicine be used? And absolutely, we use Zoom now all the time. And yes, in fact, I'm trying to coerce Dr. Berra into training for several institutions that are, if you will, under-equipped and need some help. And could we do that? Yes, with funding, we could absolutely do it. Thank you all. Thank you very much. This has been a wonderful, wonderful experience and webinar.